in terms of model at the state level, they're probably basically for a centralized, a shared, a mixed, a decentralized model. And it isn't really important except that to think about the fact that Maryland as a model is very much more in the shared to mix, kind of a hybrid of those two models in many ways. And just to give you a sense of some of the things that we in the nonprofit world do to try to support, this actually happens to be APHA's brand new hot off the press strategic plan. But you can see where we're focusing a lot on building workforce capacity. We have a membership association, so we want to engage our members. All of the nonprofits have to do that. Most of us who are member associations have members that we have to try to keep engaged. We're all in the business of championing public health. So we're both outwardly looking as well as internally looking. And equitable public health is a core value, it always has been for public health. And we do a lot of that, a lot of research. And, you know, I often hear from people that public health is not accountable. And I want to kill that one right now. We probably have more accountability mechanisms than any private sector entity. I mean, you've got a governor, a mayor, county council members, you've got the media, those of us who have gone through the many budget audits that we've had to go through all year long, every year from our legislative auditors, we have that accountability mechanism. In addition, we have the National Board of Public Health Examiners, which is there to credential people who want to practice public health. And you have the Public Health Accreditation Board, which is designed to hold accountable and accredit the actual agencies. Both of those two entities are relatively new. And the good news is, we'll talk about this, Maryland certainly has taken advantage of FAB in many, many ways. But the point is that civil society is very much up to engaging in what we do. Tragically, public health continues to operate in an incongruent fiscal environment. What I mean by that is something bad happens. And then at some point, the resource allocators decide to put a little bit of money on the table to try to fix it. Tragically, it's often a bit late, usually not enough. Sometimes they overreach, but then it goes away pretty quickly. And you would think that we would learn that lesson, but we have not learned that lesson. I've seen that happen over and over and over again. And by the way, we are now repeating that mistake from COVID. But the real tragedy we have is these performance expectations are expected to far exceed both the event and the funding. And therein lies our challenge, I think, in public health, and trying to get sustainable long-term funding and actually build system capacity so that we don't have to build it, take it apart, build it again, take it apart. I'm not against moving money around, not against cuts, I'm not about efficiency, but I am about sustainability. And that's something that we really haven't quite figured out how to do. Maryland has done better than a lot of states, just because we have a funding formula for local health officers, local departments, and in general, we've had substantial growth. We also have a mega department, so there's money that can be moved around within that entity. But if you are a state or local health department in many other states, they don't have that challenge. They have that as a challenge. They don't have that capacity because they don't have the robustness of a large department. I would argue the basic work hasn't changed. This happens to be the update of the 10 essential services. Some of you are into the functional capacities. It's just the 10 essential services rearranged. But at the end of the day, what we fundamentally have to know is when a new health threat enters the community, craft a plan to address it, and then ensure that it gets done. Those are the three core, activities that we have to do no matter what happens. And part of the challenge we have is knowing when that threat is coming in a timely way, and then getting collaborative work done to actually address it. And then sometimes the accountability resources aren't there to do that. I do think that the practice environment for public health has dramatically changed. During COVID was a real tragedy. But during COVID, the opioid epidemic did not go away. The gun epidemic didn't go away. The obesity epidemic certainly didn't go away. In fact, in some places it got worse. Our challenge with mental health blossomed. So, many of our things that we're having just did not go away, and they continue to be a problem. And then, of course, we had the monkeypox outbreak that kind of came on the tail of at least the first 2 years of COVID. Science is moving at light speed. There was a time when you could, do a study and you could sit around and you could, contemplate your navel and think about what it means. And we would send it back and forth between scientists. And, 5, 6 years later, we would come to some consensus about what it means. That's, science is being done openly, transparently, even good stuff and bad stuff. And we're trying to figure out what's what. And it's happening really at the speed of technology. And that's moving very quickly. And the research. I was around when we talked about using mRNA vaccines for HIV/AIDS, and it didn't work. I was also around when we had SARS-1, and we were talking about doing mRNA vaccines, and we thought we might be getting there. And then, of course, the disease went away, the funding went away, and the research kind of came to a stall. Good news is we were able to pick it up when SARS-2 hit here. And we actually built the vaccine in record time. Although we didn't build a delivery system as quickly, we did build the vaccine in record time. I just caution us not to believe that we can do that each and every time, because even the people that knew the science real well and the potential of mRNA vaccines were skeptical that it would work, and certainly work as well as it certainly did. And then rapid application. We during COVID, we did a lot of things that were kind of known science, using monoclonals early, distributing antivirals early. The fact that we had spent some time doing H1N1 and of course doing SARS-1, trying to figure out how to do research proposals very quickly during an epidemic was very helpful. The fact that they already had the HIV/AIDS research entities in the community that have been linked to the community very early on were instrumental and essential to actually getting some enhancement of minorities and underrepresented groups into those research trials. So we learned a lot of things about rapid application, but people's expectations now, of course, are going to be that we should be able to do that each and every time. Obviously, we're an aging population. The country still continues to become more diverse population in many ways. Fast communication. The time when I was in medical school and we owned the knowledge, we had these books that were very good at being doorstops, and we were expected to know everything from page 1 to page 2,563. But the public didn't have that information. We could give them what we thought was appropriate for them to have. But communication and information has been democratized. And so now we're no longer competing with Grandma and Mrs. Jones down the street, or Uncle John, who is sharing information on a particular issue, or in the barbershop or the beauty shop. You're getting all this very, very important information, some correct, some not. People are getting information through social media at the speed of electrons, and they're being overwhelmed with information. They don't know what to believe and what not to believe, and we're not pretty good at determining risk, and we still aren't very good at determining facts from fiction as a society. And so, the infodemic that we had during actually before COVID and then accelerated during COVID, when partnered with a political message, caused a lot of dysfunctional behavior as we went through there. And we've had other disruptive technologies. So just as we thought we had our hands around tobacco, we got e-cigarettes. We used to brag a lot about the fact that when we did our best work, nothing happened and nobody knew we were around. I remember when we had the big foodborne outbreak in Southern Maryland when I was the health secretary. I think it was maybe I was deputy then, and Marty was secretary, Marty with Dr. Wasserman. But the point was 700-person foodborne outbreak, and the governor's office was certainly interested
Yes, thank you. Thank you.
And the media had a story, more so in the St. Mary's paper. I think the Baltimore Sun might have covered it.
It was national news.
It would be the national news, but
We had national news on our front line.
yeah, nothing like, we have today, right? But now we're extraordinarily visible. We're in the fishbowl each and every day, no matter what we do. Growing distrust of expert advice in science continues to be a big issue for us. And quite frankly, health policy as an entity has now become overtly political for a variety of reasons. And so that's part of the operating environment that we have to address. I would argue the central challenge for the nation is to build that next generation public health system, structure and resource it in a way to meet the strategic needs of the nation, which, believe it or not, means that you actually have to sit down and figure out what the strategic needs of the nation are, prioritize them, and then figure out how you're going to resource them, and then build the infrastructure delivery. Every system gives you the outcome that you perfectly decide to do, period. That's a fact. And so when we have failures and systems don't work well, it's because we've designed them the way that we have and resource them the way we have. I would argue that the ideal system is one that's robust, and again, that word sustainability is there. I still believe that the public health leader serves as the chief health strategist of every community at every level, that the agency needs infrastructure to deliver 10 essential services. You may only do a little bit of service delivery, or you may do a little bit of this or more of that, but you need to have the capacity to do that and bring that up when you need it. Our data systems are continue to be inadequate. I remember, again, my boss, Marty Wasserman, just came on board as secretary and told each of the 24 local health officers they had to buy a computer for the department. You would have thought that he was taking away their kids, Well, we had such resistance to buying a computer. But you should know that in those days, a computer was about $10,000, and that the cost to move data, particularly if you were crossing the Potomac, was enormous. And didn't have the money for it, and so, but we did do that. And of course, we continue to evolve. And now, those of you who send kids to school know that your first child, it was a one computer experience. And now the children going to school today is a one computer, 2 iPad, 4 cell phone experience. And they all have to talk to one another and have to be interoperable. Having said that, we have not resourced the public health system in order to even move this. We were still moving paper by fax machines during COVID. And that's 30 years ago when we recognized that we ought to stop doing that. Obviously, adequate and sustainable funding is something that we need to do. And we talk a lot about partnerships. We don't really do it as well as we ought to. Partnerships are something you have to engage early, and even when you don't need people, and to engage them. And I believe accountable, credible health system. I believe that the Public Health Accreditation Board ought to tie funding to accreditation. It's taken me a while to get there, but I do believe that that's important. Some of you may know Kay Bender. Kay's a past APHA president, former deputy, I think, for Alabama, Mississippi state deputy health officer. But she's a nurse and really one of these wise people. She was a president for many years of the Public Health Accreditation Board. And her and I were having a conversation about accreditation. And we were talking about the fact that, boy, nobody really wants to have that accountability and get accredited. But once you get it, nobody wants to lose it. And those of you who had accredited entities under your jurisdiction know that if you want to get your county leaders' attention, is you let them know what the accreditation risk is for their schools, for their jails, for their police departments. I think public health needs to make that something that's very important as well. Whatever the next generation public health system is, it needs to fully integrate data infrastructures. Many years ago, President Eisenhower decided we needed to have a national highway system. And they passed laws, they resourced it, and that's why we have a national highway system today. We had lots of roads that were not connected to one another, but you couldn't move other than Route 66. You couldn't move from one part of the country to another. And we need to do that once and for all. We need to build a health information highway. It's really unfortunate that, you know, pick a food delivery system or a system, you know, like Uber or Lyft or can move you anywhere around the world. You can get money out of any ATM around the world, but we still have trouble moving an EKG across the street. We still have difficulty knowing that George Benjamin data system A is the same George Benjamin data system B, so that we can compare those two systems. I'm glad to hear that HHS finally made the Office of National Coordinator and Assistant Secretary. I hope that now comes with resources and infrastructure, and that they actually build this global national health information highway with all the data systems that go with it. The fact that CDC, every time we have a new disease outbreak, has to go in and negotiate with each and every state to share data makes absolutely no sense whatsoever. So we have a lot of work to do with that. And we need to be able to do a better job forecasting diseases, not just infectious diseases, but chronic diseases, et cetera. We have the science, we know the knowledge to do that. We just haven't invested in that. We need a workforce with enhanced skill set, which we'll talk about. We need to build much more better public trust and improve the public's literacy. So the downside of we had COVID and all this conversation going on, in my mind, the good side is we had, for the first time, a whole nation talking about health. The fact that we had people of all political stripes, levels of education, political ideologies, debating about masks. Some got the wrong message, some got the right message, but the point was that they were having a scientific discussion. And so we need to make sure that we improve on that and improve the public's health literacy so that they are better at having these debates. Even if they may not agree with me on what something I think, having an intelligent scientific debate, starting with the same facts, same understanding, may get us to different conclusions, but at least we can have that conversation intelligently in a nonpartisan way. And of course, operationalizing health equity throughout the system is going to be important. Diversity, equity, and inclusion, I did say that word. You notice there hasn't been an earthquake, I haven't been struck by lightning, it's not over yet. Is real and something that we have to pay a lot more attention to as we go through our system. I think such an integrated system can address any health threat. The idea of being able to put data from, you know, school absenteeism, emergency departments, and the health department, and all those data systems together, which we know right now we already do. We have maps that, you know, show us where high-risk issues are. We just don't have them being done in real time so that we can make decisions. Is very, very important. I think enhanced skills, I think as we're looking to the future, we have to improve the science and technological skills, the molecular and technological skills of people throughout our system. And Maryland, you know, was one of the first states, in fact, the first state to do the infant blood spots here in the state of Maryland. We were the exemplar there. We started that, became a worldwide phenomenon. And yet, as I was both deputy and then secretary of Maryland, we were beginning to lose our edge on the technological stuff because the private sector was able to do this, got the equipment, got the new technology. In the days when you would want to be a laboratorian in a state health department, because you got to see really weird stuff, real bugs that nobody else did because you were the reference lab. The private sector is beginning to pick those duties up because they have the resources to be able to do that. And yet I'm not so sure that the commercialization of that's a good idea. I do believe you still need to have a government entity that's a reference lab for most of this stuff. We need to do a better job of being trained in disease modeling, data science, our leadership skills. So I believe very strongly that public health has got to stop believing that we're not political. Public health by its very nature is a political discipline because we do things by policy. What we need to make sure we don't do is we're not partisan as part of that process. We need to think about political science as a science because it's the art of trying to convince people that what you want is the right thing. And so you need to have the evidence, and science, and the data, and the communications tools to try to do that. We need to do better at meta leadership. Meta leadership being the ability to manage up, down, sideways, particularly in things in which you don't directly control. Engaging communities and diffusing conflict. We had a lot of that during COVID, of course. And regulatory skills. Boy, you know, how many people have just gotten their first job in public health and overnight, suddenly they're a regulator? No idea what that means. I remember my first public health job in DC. I was an ER doc. I was a department chair at a hospital. I understood the regulations around being a hospital CEO, you know, for the department there. But my first day on the job, somebody brought in one of those TV things for me to sign, commit somebody. You know, I had a couple of days later, I had some regulatory thing I had to sign off. And you know, I had no idea what my regulatory authorities were. So understanding how to be a regulator is certainly an important skill. Then obviously all the communication skills, particularly risk communication, is going to be very important, and increasingly social media skills. Now, some of that will happen over time because the folks younger than me do this and are growing up with social media. But for us old folks, we're going to have to develop those skills as we go forward, and clearly advocacy. I tell people that you can do advocacy, all right? And when you do that, it may not be wise in some cases for you to do it in a particular issue, but that's why we have the organizations like APHA and ASTA and HO for us to do the advocacy collectively that you may or may not be able to do in your job. So let's talk about the Maryland Department of Health. I like to argue Maryland is a national model of what the health department will look like. I absolutely do believe that this mega agency that we have with everybody in it is very important. I think that it needs tweaks. Everything can be tweaked. The fact that we have an organized system where every jurisdiction has a person in charge of public health. They all have a board of health. That relationship, again, it can always be improved, but I think that that's a model that has worked in my mind for Maryland. And I think it needs to work, and I think I'd love to see other folks do that. But what it does allow us to do really is to attend essential services and the functional services. They're in the department. They can be reorganized differently, and they can be made more efficient and all that kind of stuff. But at the end of the day, there's nothing that happens within the Department of Health in Maryland that doesn't undermine, it doesn't work along with those 10 essential services and then some. Our data systems, the fact that we have all these various data systems. Now, they can also be improved, and I know they were used a lot during COVID. And I think some innovative things were done with the data systems, as I understand it, in Maryland. So we're well positioned for the future. But I do think it's good, obviously. Whatever the next phase of that is, needs more investment. I'm not the expert there, but that might be something you might want to figure out where the next phase of putting that together. They have the top-notch national, part of any national highway health information highway system. You can also do that in the state, and realizing that there's a region that we're practicing in. Making that regionalized would be very important. Funding can certainly be improved. I've been around when we've cut funding and increased funding, and the all-payer system is a potential game changer in Maryland. The fact that I would love to see the all-payer system for everything in health. But I think that's where in many ways, that's where we're going, because it creates, in essence, a global budget and allows for you things to move money around in ways that I think can be innovative. And I do think, though, we have historically underengaged business as part of that. We need the business community to see that as something that's important. I went and looked up what we had on FAB. So, as you know, we've got many of the local health departments, at least 12 of you, that are FAB accredited, and at least the public health service within the department is FAB accredited. So I think that we're well on our way to meeting that goal. I think the potential for transformational change is just absolutely there. You've got the core public health infrastructure. We've got to think more about how we incentivize people to go into governmental public health. One of the real failures of the public health pipeline that we have, 2 schools of public health and a couple programs, and yet people aren't dying to go work in the state and local health departments. You know, I think we need to fix that. We need to find ways to incentivize people to go into governmental public health. I mean, it's really a shame when you have, you know, Hopkins feeding the nation in terms of people getting degrees in public health. University of Maryland school is going like gangbusters, and yet, you know, we're still struggling to get people to work in governmental public health and some of these wonderful jobs. I mentioned the health information system. I won't go that, and the data systems. And I think, you know, this issue with the all-payer system, the ability to bring in all of the social service data and link that data in a meaningful way. And again, we ought to go to the lawyers and say how to do this, not can we do this? Because I hear all kinds of excuses why you can't share data. And when you actually go look at many of these statutes, there are no prohibitions to doing it. There may be some funding rules that you have to get around, but in most cases you can waive those and get those waived by the funders. But the idea is trying to do that, to get an all-payer system across all health entities. I think will ultimately allow us to drive optimal health, but based on the blueprint. You know, here's the goals of our nation, and then holding ourselves accountable to do that. I also think that Maryland is in the potential driver's seat to become one of the first states in the nation to truly achieve universal coverage. Now there's a state that's out ahead of us a little bit, and that's Hawaii. If we want to challenge ourselves, Jack Lewin, some of you may know, Jack was instrumental in building a near universal healthcare system in Hawaii when he was the health secretary many, many years ago. He's now gone back to Hawaii to finish the job in this new environment that we're in. But I think Maryland has, with the all-payer system, has the ability to ultimately achieve that and kind of streamline these programs in a variety of ways to try to meet some of those goals. So that, I mean, thank you, and I'm happy to take any questions.
I'll speak first, and then let's open it up for questions from here in the room and online. First of all, what an honor and to have somebody with your vested experience in Maryland and national outlook here at our meeting. So thank you so much for taking the time to come and share your perspectives. I think the thoughts you shared are incredibly potent and very relevant to where we are as a commission and where we're headed. So I'm eager to open it up for discussion. But while everybody's queuing up their thoughts for questions, I'll throw one out there. You mentioned the challenge that we're having with governmental public health workforce. And certainly we're seeing that challenge here in the state and local health departments. And yes, we can blame the effects of the COVID pandemic and so forth, but a lot of that challenge was emerging at full force way before the pandemic for all of us. You also referenced, our stellar schools and programs of public health here in Maryland and how we're just not connecting the dots and getting students coming out of these programs, schools, even bachelor's level programs, into our governmental public health workforce at state and local level, or at least enough to address our shortages. So I'd love to hear some additional thoughts from you as to how we might better connect the dots there in that pipeline. How can we better fill that pipeline? How can we better ensure there's accountability of our educational institutions when it comes to our governmental public health workforce?
Yeah, let me start by saying, as a nation, we don't know what a public health worker is. Yeah. And we've been pushing very hard at the national level to get the Department of Labor to actually define under what's called the SOC, Standard Occupational Classification, what public health is. You go to the list of jobs, you don't see anything that says really public health. You see epidemiologists, you see statisticians. The nurses are just trying to get something that says public health nurse better defined. But an epidemiologist is not an epidemiologist, not an epidemiologist. I mean, an epidemiologist doing research in a rat lab, very important research, but that's not the same epidemiologist that's working in a health department, for example. And so I think when you're doing enumeration, you can't count what you can't count. You know, it's if you count all the internal medicine people in the country, and you add in that count, and you're trying to look at patient care, and you add in that count all the administrators, you're gonna, you know, overcount the number of people you have. You can't really, you know, do good forecasting that way. So we need to do that. You can all do that in Maryland. You know, figure out what the job categories are, and then really do some good enumeration around what those jobs are, and then you can figure out how many of them you need and where do you need them, and then you can put in incentives to get people there. And yeah, you know, loan repayment, scholarships programs are a proven way to do it. We've done it with nurses in the state, in particular. You have to look at the fundamentals and make sure we're training enough people in the right disciplines. But again, you can't do that until you know what your denominator is, of how many people you actually need in those disciplines. So that's the first thing, is getting a good count. Yeah, the Beaumont and NACCHO and ASCO do these surveys periodically, but they're really guesstimate surveys. You know, they don't have the, I mean, they're good for the kind of estimates that we're making. But I remember during COVID, we were asked, how many people do we need and where do we get them from? And we were guessing. We were guessing. There was a 100,000 person figure floating around. And, you know, that figure was a guesstimate. And we held to have that figure when we lost 40,000 workers, 40,000 off of what base? Because that number is an old base. The original base number of 500,000 public health workers that's kind of floating around is kind of the number people talk about. That was Chris Gebbe and Hugh Tilson. I remember they were at a bar at some meeting on the back of an envelope doing some guesstimates. And then they did some reasonable studies, and then they got published. And that's how the kind of 500,000 governmental public health number came from. But it was many, 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 many years ago. And things have changed. We also know, we don't really know why people left public health. We know that some people were badgered and bruised and tired. But for about 10 years, people were saying they were going to retire. And then COVID made people say, okay, I'm done now. So age, burnout, all that. But as we go forward, as you know, one of the most popular curriculums in schools today, including undergraduate public health programs. I mean, undergraduates in public health. So people want it. They want to do it. We just need to figure out how we get them in. Now, there are payment issues. We do have to right size the payment, but that is an issue for many governmental workers. So it will cost some money to do it, but the fundamentals is counting right, figuring out what the numbers we need are, and then prioritizing what we need, and then figuring out how we pay them adequately to keep them in their jobs.
Thank you. Thank you. And I know we have several academic partners in the room, so if there's a desire to continue that conversation, please feel free to type it as well. But Fran, I'll turn to you.
Thank you, Dr. Benjamin. So it's great to hear you. I have a quick comment and a question. My comment is, I don't think your CV, your bio does justice to a number of aspects of your life. The one that I know about is when you served as deputy secretary and also as the secretary here in Maryland. Those were, seems like a long time ago, 1999.
No,
16 months after Dr. Benjamin became secretary was 9/11. Okay, and a couple months after that was the anthrax attacks. Okay, so this was so far long ago, but yet, it's, for some of us, it's like yesterday. That was at a time when there's no concept of bioterrorism, except Dr. B, who had just come from the Army, from Walter Reed, and he would come in to our health officer roundtable, and he'd start talking about bioterrorism and emergency preparedness and incident command. And at that time, we thought, like, what is this language? And then 9/11. So my point is that leading into that expertise that you had, made you the national leader, as the Pentagon was assaulted, as obviously World Trade and Pennsylvania, and then the anthrax attacks around public health. And so the public health response, emergency response, really got its modern roots that week, right? And we have taken off since then. So that's all my comments, okay? Now here's my question, right? You said very appropriately at the beginning, governmental public health is the one entity that cannot walk away. Everybody else can leave if there's a crisis. And so I guess my question to you is, the next crisis, whether it's a pandemic or it's a cyber attack or it's some other kind of crisis that really paralyzes our society, we can't walk away from that, right? So I think all of us are recognize that, but we have a great deal of trepidation about our ability to meet that crisis, whatever that crisis is. So the one thing that I think, if you can comment on emergency preparedness as an aspect of public health, and perhaps one that goes to the core of what might be attracted to new public health workers, people who are maybe paramedics right now, or just a wider array of people that might come into our workforce in order to do emergency preparedness. So that's a long-winded.
Yeah, well, thanks, Fran. You know, the challenge you have, so the benefit of having been both an internist who went into emergency medicine is I've been in the contemplative part of medicine, and then I've been in the forward-leaning OS part of medicine, you know, where you're sitting in the room and nothing bad is happening. You're enjoying coffee, and then all of a sudden, you know, someone's about to die in front of you. And I think one of the things is an attitude. It's an attitude adjustment. CDC is being pressured under this right now because they're very contemplative. You know, they like to cross all the I, you know, dot all the I's and cross all the T's before they go public on anything, before they communicate anything, before they engage people. And I think in public health, we gotta be much more forward-leaning today because of fast science, fast communication, fast bad things happening out there at the speed of sound. And at the national level, I've been trying to argue pretty vigorously that a health emergency is treated in a very poor manner at the national level. That if we have a hurricane and tornado, everybody knows what to do. FEMA knows their role, everybody responds, and it works. You know, the incident command structure gets fired up very quickly. But health emergencies tend to be a little more slow going. And so, you know, CDC kind of gets involved, and then all of a sudden it crosses state lines, and now we got 2 of these, and, you know, maybe now we ought to bring in, you know, HRSA because community health centers need. We kind of crawl into these things. I think we need to keep our emergency preparedness systems warm all the time. That means that we need to lower the bar for actually responding. That means we need to activate our command systems much more aggressively than we do today. And we need to be more forward-leaning for these emergencies so we can stamp them out long before they become a problem. I've been a critic of the avian flu response, for example. I know that they're working pretty hard, and I know there are challenges in working with farmers because they don't have those business relationships with the farmers. But you know, we don't have a real good clue about how many people are infected with avian flu. Good news is it's a minor, you know, right now it's pretty a minor illness. But when it breaks out, it might break out. We know what flu looks like broken out. And so we've got to be a much more aggressive issue here. We have measles outbreaks that are breaking out all over the country. And again, we got to be responding in a much more aggressive way about this. So I think that we don't want to scare the public. We don't want to alarm people, and we don't want to make people numb. Because if you declare emergency too often, people, nothing, you know, everything's emergency, nothing is. But you can be much more forward-leaning, more aggressive about these things to stamp them out. You know, trained in emergency medicine, like in train, right? You know, in the early days of emergency medicine, one of the principles that we practiced very early on is that everybody who we interact with in the emergency department is about to die until we prove they're not. The alternative approach in medicine is that everybody is going to be treated and they might have an illness, but dying is something that's unexpected. Emergency medicine has that on the opposite way. We expect everybody's going to walk in that door, it's about to die on us, again, until we prove that they're not. And I think in public health, we need to make sure that we now think that to some degree, every new problem we encounter is going to get worse until we prove that it isn't. We can prove that it isn't pretty quickly, but we need to walk in the door with that mindset.
Thank you, Dr. Benjamin. I really enjoyed your presentation. My question is really around the tenet that you stated regarding operationalizing health equity. And as you showed in the graphic for the 10 essential public health services and many of the other things you shared, equity is at the center. But in terms of operationalizing that, I can say that I feel that not just in Maryland, but really throughout the country, we've fallen short. So I wonder if you could comment on maybe 2 or 3 specific tactics, best practices, recommendations that you have so that we can really truly operationalize equity.
Well, I think the first thing is that every time we do something, we ought to ask ourselves fundamentally as part of, the initial part of our thinking about a program or implementing a program, are we doing this in an equitable way? Who are we leaving out? Who's not been part of the conversation? And you will find that, people are going to be left out. Now, it may be okay. And when you leave the room thinking, I think it's okay to leave people out, but it may be okay to prioritize. So in the early part of COVID, although people have criticized this, we left pregnant women and children out of the early studies because we were very worried about what would happen if we gave this new vaccine to them. And that, in many ways, once we knew the vaccine was safe and effective, became ultimately an equity issue, and then we needed to fix it real quick. But we also knew from many, many years of responding to disease outbreaks that we should have leaned into community health centers earlier. We should have leaned into public health workers earlier. We do this from H1N1 that we left people behind. We should have activated our programs to train barbers and beauticians and other people, trusted messengers early on. This was not a secret. Steve Thomas and the folks at University of Maryland published that stuff from H1N1. So these things were not secret. We just kind of, we decided drive-throughs were neat to get vaccinated and get tested and all that kind of stuff. And, we're all saying, but what about the folks that can't get there? And everybody said, we'll get to it. So I think operationalizing it very early on. I think the other thing is, I just completed a study with the National Academy of Medicine. We looked at that unequal treatment report that was done 20 years ago. We just did a kind of a redo of it. And what our fundamental finding was that discrimination and inequity is built into our health system today. It is, again, designed to give you inequitable outcomes. Let me give you an example. We pay providers differently from Medicare and Medicaid.
Thank you.
I understand why we do it. I understand Medicaid was initially just some money to pay for people who are uninsured to give the providers something. Those days are long gone. Medicaid covers half of pregnancies in this country. It's going to cost us some money to fix it, but we will be enormous savings, if we fix that, and we have to fix it over time. I remember, when we were having trouble getting primary care providers on my watch in Maryland, and I don't know whether we were finished the project, but we started paying primary care docs more. We increased their rate. We put more money in the budget so we could pay primary care doctors a little bit more, so that we could try to stem off some of the losses and get them more involved in the programs. I think there are ways for us to just operationalize this. And again, sitting down and thinking about this. Carlissa Hussain, when Carlissa was the Dr. Hussain was at the health department and was running the, what was the name of the program? Yeah, but it was called something else before that, when we first got the tobacco restitution fund up and running.
Right.
But whatever it was called. And we sat down and we said, okay, how are we going to address, we had decided colon rectal cancer was going to be the cancer we were going to address. We did some prostate cancer too, but colon rectal was the big one that we were falling behind. And Carlissa said, look, we need to work real hard to both improve on screening, so we have equitable screening, and then make sure people are treated. And I saw some data several years ago that actually showed that we had closed that racial gap on colon rectal cancers in Maryland. So you can do it. It requires planning, deliberation, thoughtfulness, and follow up. So I hope that helps.
Yes, thank you.
Excellent. I'll go online to Commissioner Chris Brandt, who's joining us. Thank you, Chris. I'm glad you raised your hand because I was actually going to put you on the spot and ask you to speak.
You're muted. Can't hear you.
Yeah, Chris, if you could unmute. I think you're still muted on our end, Chris.
It's on his end. Looks like.
You're to the back, is there a way you can unmute?
Can you unmute him? Okay, that's speaking.
Chris, if you want to type in your question or
Yeah,
comment into
that's
the chat
fine.
box, we can read it out for you. We're still seeing you guys muted.
Yeah, no, he's muted from his end.
He's unmuted. You're muted on your end.
Thank you. While Chris is queuing that up, I'll bring up another topic, and once we get his comment, we can switch over to that. But there, we've at our commission meetings have talked quite a bit about the evolving topic of the roles of healthcare system partners and governmental public health entities, and in addressing social needs. And health equity under the umbrella of, what is referred to as population health in these conversations. So I'd love to hear your perspective on that in particular as to how these kind of evolving roles and responsibilities can be synergized and what makes sense given what we think of our public health system and governmental public health entities serving as a chief health strategist.
So let me say two things. So first of all, addressing individual social needs is very important, and we should still do that as clinicians. And health entities ought to be able to think about what that means and for their individual patients and their population of patients in terms of helping. But I still remain fascinated. Fran talked about when I was the deputy and she was deputy. We would go to all, we had 80% of the department was under the public health service on the ground. We only had $1 billion of the $5 billion, but we had 80% of the department, and we had most of the budget hearings. And I would go to these budget hearings. It would be me, my budget director, the program director, the chair of the committee, the chair of the committee's aide, and somebody couldn't find any place else to eat their lunch. And then I'd go to the Medicaid hearing, and you couldn't get into the hearing room. And or we go to a hearing for certificate of need, and somebody wanted to build a hill report. Couldn't get into the room. And we were talking about building a cardiovascular cath program. You couldn't get on into the block. I would love to see the health system spend some of their precious legislative time showing up the health department's budget hearing, the hearings on tobacco, the hearings on zoning. We know that zoning, liquor store density. If you reduce liquor store density, you can improve the health and mental health of a community. You can reduce substance use, alcohol misuse. I would love to see them engage in partnerships. They know their communities. They're doing community health needs assessments. I would argue that there's a business model for them to partner to make sure that we can convert some of those little grocery stores, because it's not there's no food in the community. It's that it's high fat, high salt, low nutritious foods. And those stores all have trouble maintaining a good business model. But there's no reason that other businesses in that community can't help ensure that we have adequate grocery stores in those communities. Greater Southeast Community Hospital in DC, which is not too far from here, it was on the DC Prince George's County line in Maryland, was in Ward 8, and they had some real challenges with infant mortality. They spent a fair amount of time and effort addressing maternal child health social needs in the community by trying to deal with domestic violence programs and food programs. And this was many 30 some years ago. And they were able to improve the infant mortality and well-being of the women in those community with the help of the city and the city health department. So I think that there's things that the healthcare entities in a community can do, and we should judge them by what changes in the community. It is true, tragically, that some of the most well-endowed, most well-respected research entities in our nation are in the most impoverished communities in our nation. And they remain impoverished until those communities do gentrification and throw all the poor people out, building their new buildings. And I'm old enough not to worry about whether I offended anyone. And the truth is, we ought to tie funding for capital projects and things for them improving the health and well-being of the community. Let them figure it out. But there are things they can do from a population perspective to change the economics of their community. Now, they're going to argue that's not the business that they're in. And I would argue they're in the health business. And if they're not improving their community for optimal health, then they're not doing their job. And, you know, I mean, I've had now cataracts done in 2 hips. I absolutely understand, and, you know, practicing medicine, the wonderfulness of the acute medicine that we play in this country. I mean, we do wonderful things to improve people's health and well-being in this country on an individual basis. But until we fundamentally change the social society that we're living in, we're not going to achieve the real outcomes. We'll continue to spend twice as much as the industrialized nation on the planet and getting the worst outcomes. We're not getting the best value for our dollars. So from a business perspective, doing that will help, I believe, improve the value and return on investment. We also have to measure the return on investment differently. It cannot just be health outcomes as we traditionally measure them, but we also have to look at, you know, less kids going into juvenile justice programs, less kids going to foster home, less people who are food insecure. We have to look at those as measures of whether or not they're doing what they need to do. And they need to do that in partnership with other entities, and they're not there by themselves.
Thank you. Thank you. Chris Brandt from online, I think, is ready to unmute. If you are,
Yep.
please go ahead.
Can you hear me? Please tell me yes.
He's unmuted.
Yeah, you're unmuted now for us.
Okay, can you hear me?
We can't hear him.
There's a speaker to be judged.
Hello, hello? It says not me. Test, test, test.
Yeah.
I still can't. You want to type it in? Oh, you can hear.
We can hear you online.
We can't hear him in this room. That's the problem.
Okay.
We can hear Chris now. Maybe it's just the volume. Are you? Oh, okay, it's on Dr. Levy's. All right, sorry. We're gonna, Chris,
Test,
just
test.
hold for a minute, if you don't mind. We're gonna
Yeah,
have
no.
Dr. Levy, his access and project your volume. Thank you. Sorry about that.
Possible is for his hand. It's possible is for his hand.
Why don't we do this? Is he on your phone?
Test, test.
Chris, go ahead and speak.
Yes, sir. Can you hear me? Anybody?
Go ahead.
All right. Dr. Benjamin, first, thank you so much for joining us. An honor to have you. Can you hear me still?
Yes, we can.
Awesome. So I guess you have really unique experience, both as historically as a delivery system leader and as a public health leader, now a very prominent public health leader. I'm just wondering, and you touched on Maryland's unique rate setter, sort of our opportunity to sort of shape incentives a little bit differently, which that process is currently underway. Just wondering if you have, given your experience and wisdom, if you have some ideas or vision for what are the types of changes that if you could wave a wand, how would you adjust incentives so that the delivery system would participate more, especially hospitals and health systems, but would participate more in the health of our communities, in the public health, sort of moving the needle on public health measures?
Yeah. So can you all hear me now?
Yes, let's just make sure everybody online can now hear Dr. Benjamin.
Can everybody hear me now?
Yeah, we can hear you.
Yes.
So,
Are you okay turning yours off?
what I would do is,
Thank you.
I would, you're one too many things. I pick 2 or 3 things that make a lot of sense, statewide, and wrap them into, your all-peer model. It may be food insecurity. And pick 1 or 2 things that are consistent across that. And then that work with the hospital association and the social service agencies and the health department to come up with a plan to address that across state, as a model and demonstrate that what everybody's role is. We don't want the hospital
Sorry,
to
should have
do
been-
something that they don't. We don't want the hospital to do something they don't need to do, or they're not best equipped to do. There's a role that they can play. It may be helping identify those people who are food insecure and come in their systems. But we ought to be able to link all those people together because we know that where they are. We know the communities that they're in. We know the zip codes that they're in.
Yeah.
And we ought to be able to identify them in a way that's appropriate, without violating inappropriately confidentiality. And then come up with plans, but the goals have to be improving health, improving whatever that social determinant is, as co-benefits. And then, just because it's important for the economists to understand it, come up with what we want to measure in terms of what the fiscal benefit is. And we have to do it over a long enough period of time to make that sense, make it make sense. For me, food insecurity is a big one. Things that affect maternal or infant mortality are big ones. Violence, big one.
Yeah.
That I think we can make big differences, over time. Longer term things are, issues with juvenile justice, substance misuse, and behavioral issues that are traditionally more challenging to deal with, but they're much longer term things. It might even make more sense for the hospitals and the health delivery systems to, things that they absolutely want to do. Certainly, we want to improve colorectal cancer, cancer screening, and then look at the full continuum of that. Again, there are food insecurity issues there. There are support issues there. So I don't have the magic wand because I don't know the data, but the data's out there, and someone just has to decide we're going to look at all these plans, find something consistent, and work on it. And by the way, you'll be surprised at what you find. I remember when I was a DC health officer. As a DC health officer, I was very much concerned about gun violence. And as a health officer, I sat as the chair of the Council of Governments, Health Officer Committee in DC. And I can tell you that the health officer in Charles County, the southern Maryland counties on this side of the river, all the way up to Frederick, gun violence wasn't their issue. A little bit more in Prince George's County, but that really wasn't their issue. And we ultimately came up with immunizations as something that we could all deal with. And in those days, immunizations for kids was in the 60% level. And so we focused like a laser on that. It was also a national initiative to do that. You may remember President Bush, Barbara Bush, Betty Bumpers, Senator Bumpers' wife, all wanted to do something. That's when the Healthy Start grants were starting. And so there was money, there was an opportunity, and we agreed on immunizations. We were able to collectively, working across all of our systems, including the hospitals, to bring the immunization rates up in the whole region.
Chris has a follow-up to your response. I think we might need to, if you give us some quick.
Just real quickly, I'm wondering, I'm particularly trying to kind of ask you based on your experience as a hospital leader. So Maryland has, as part of its rate setter, has a program, the MPA, that basically attributes every Medicare patient in Maryland is attributed to a hospital, and the hospital gets a basically a bonus or a disincentive based on how that, like St. Joe's, where I serve on the board, has 25,000 Medicare patients that they get, 2 years later after the fact, but they get a bonus or a disincentive if that population is cared for effectively and efficiently, basically, or not. I know there's resistance to this. Hospitals aren't really built to do this work, but I guess I'm just trying to tap into your, because you've seen both sides of this. If that were expanded, to include if that became more of the incentive and maybe a larger population, maybe you include commercial and Medicaid patients, how do you feel like that would impact both the delivery system and the public health outcomes? Like if basically hospitals were paid, instead of being paid more on a fee-for-service basis, if they were paid based on efficiency and quality metrics for a given population.
I think the challenge is that we keep talking about the hospitals being in the all-payer system all by themselves. And I think we need to bring other people into the all-payer system. Doctors and nurses ought to be in the all-payer system. Providers ought to be in the all-payer system. Long-term care ought to be in the all-payer system. And everybody ought to, I know the hospitals just drive them crazy, right? When I said this before, several years ago, we actually almost got the physicians into the all-payer system. We actually passed legislation to bring them in, and then it got reversed the next year. When I was secretary, I was spending a lot of time physicians worrying about their pay being cut because the insurers were coming in and deeply cutting their payments. I know nobody wants government to control rates, but I think that you can do that. But I think a lot of other people have to be incentivized in some way to participate with the hospitals. The hospitals cannot be the only person who benefits or is penalized from the all-payer model. Right now, I think we still do this. Depending on where you are if you're attached to the campus, it's part of the all-payer system. If you're not, it's not. Is that still true? And so I think, we can bring others into that model carefully to where there are actual efforts that show that the hospital and the patient, first of all, the patient benefits. So, we're sending people home from hospitals and their hospital get penalized for people returning too soon to the hospital. So there's an opportunity there to look at all the things wrapped around the social issues wrapped around patients returning to the hospital, and then figuring out how you pay for that not to happen, and then incentivize the system to get paid for that. We know that children with asthma. There are models around the country where they are now, paying for things like air conditioners to reduce reduce asthma outbreaks in kids and attacks in kids. Those are very narrow models, but those could also be, the all-payer system could fund that kind of stuff. And we do projects with the all-payer system, right? I think they're still doing those kind of experiments with the all-payer system. Again, this doesn't have to be system-wide, but I could see a innovative hospital stepping up to the plate, identifying a problem that they have. And since it is a Medicare waiver, seniors could easily be the target population. But again, the fact that all payers are in it, I don't know why we're limited to just Medicare patients. Since everybody has to participate at the store.
Thank you.
Chris, does that help you?
Yes, it does. I guess just for what it's worth, I mean, the hospitals complain that there are so many different programs and the feedback loop is so slow. Like they do work, 2 years later, maybe they get paid for it or penalized.
Let me fix that a little bit. I do think we have to turn around the system so that people see immediate return financially. If I was king of the world and I was, running the universe today, I would have a system which with an all-payer model, with everyone in and nobody out, that use kind of a Medicare Advantage type of model. Where we have to fix Medicare, we have to fix the problems with Medicare Advantage, but that people would get paid right away on clean claims. Maybe 80% of the claims would get paid right away. There's no reason not to do that, right? To pay clean claims right away, and then reconcile the small number of claims that we have to reconcile later. And for really good performers, you could raise that figure. So the real incentive is trying to reduce the amount of back office work people do and reducing their administrative burden. I think if you can help figure out ways, and we've got some ideas of reducing administrative burden for the health system in general, that's a win. I mean, I was running a business and you told me just that I could get all my clean claims paid, 80% of all my claims paid right away, so I don't have a cash flow problem. Boy, that'd make a big difference in my operations. I don't know what that percent ought to be, but it would help me.
I'm going to go, we're going to do commissioner questions first, and then we'll turn to work group members and others who are joining us today. Thank you for your patience. So the next is Commissioner Nilesh Kalyanaraman, who's the Deputy Secretary of Public Health Services at the Maryland Department of Health.
Good to see you again, Dr. Benjamin. It's been a while.
How you doing?
So I just wanted to harken back to something you said earlier about the funding boom bust cycle. Obviously, we're living through that right now, watching it try to happen again. How do you think about trying to shift that? Part of what I heard is, making sure that our emergency ops kind of approach, always being ready, is like we keep that muscle flexed. But I'm trying to think about how we get out of that cycle and how you think we can get out of that.
Yeah, we got to convince the resource allocators. The amount of money. First of all, there are parts of the budget that continue to grow. Medicaid often crowds out everything else. I understand that. But the public health part of the budget is budget dust in the budget. Let's stop cutting it. And let's have a plan to grow it over time in a sustainable way so that we can maintain the infrastructure. Now we have to make a coherent argument that how destructive it is to people, but we need to stop doing that. And I think that we need to pick parts of the budget that we really want to support. So when I was the secretary, one of the places that I, based on experience, having been in DC and then in Maryland, anything the medical examiner wanted, I gave them. They were always thoughtful requests. They never asked for more than what they needed. But I understood what happened if you had an under-resourced medical examiner's office. All the criminal justice issues that fall out from that are just too terrible to tolerate. So I always made sure they got funded, you know, on top of my list. That was very important because it had so many bad ramifications. I think we need to make the same coherent argument about public health and core public health funding. And we need to be tracking it. And we need to understand what it, you know, what it means to be adequate resource. And but now we have to return on that investment. We have to document our value each and every day. And part of the problem we have is that we're visible, but we're invisible. And so all of the time we prevent stuff from happening, nobody knows about it. So we have to do a better job of telling our own story. And every time something bad doesn't happen, we need to, you know, put up a sign that says, you know, 25 days, no injuries, so that people know that we prevented stuff from happening. It's a very difficult thing to articulate, but we have to do that. And we have to build that value. But from a budgetary perspective, the public health budget is budget dust in the sum total of the state's budget. And we need the advocacy community around us, you know, to demand it, you know, in concert, that beats on the governor's office every day, goes and see the members of the appropriations committees every day, and remind them that this is not a big issue. And of course, you need champions. You know, you need champions and legislative champions to do that, to make sure that happens.
Thank you. And, you know, of course, very appreciated comments. Obviously, as was recently announced, there was a significant cut that local health departments are dealing with right now to the core funds for this fiscal year. That was just recently announced. Thank you. I'm going to move to Commissioner Camille Blake Fall, who is also the Maryland Department of Health Director of Office Minority Health Officer.
How are you?
Hey, how are you?
Thank you. I wanted to just circle back to your earlier observations about changes to our global payment system and how Maryland funds its healthcare delivery work, and share with you the good news that under this Medicaid, Medicare ahead model that's come out from CMS, we have just the opportunity that you're speaking to really more robustly weave in our primary care physicians into this value-based care system so that it actually works in the way that I think, you know, the triple aim, quadruple aim was meant to work, and incentivize primary care physicians to participate, to take all the patients, to do your decode screenings, and to do all the things that ultimately, you know, bear the fruit that you were speaking of in terms of, you know, community social needs changes. So that work is underway. Also, a part of that is our equity analysis and sort of how we weave in equity more explicitly and robustly. I've spoken about this a couple of times now, but the challenge that I continue to wrestle with, and one that you sort of affirmed for me without knowing it, is that we are spending a lot of time thinking about the individual health-related social needs, so the diseases that we can treat, and not so much about the social determinants of health and the more broad community-based wellness concept, and how we fund that, and how we know that those upstream drivers really make all the difference. And so there's a real tension, I think, for me, because CMS is really focused on individual health-related social needs, because it's what they can control, right? They can't control education, they can't control transportation, they can't, presumably, but it does make you feel like you're gonna fix things one by one, but at a micro level as opposed to a macro level. But hopefully under a head, we can really weave some of that more holistic thinking into work. At least that's the plan.
Yeah, you're right. They're challenged by some of the statutory things that they have to do. But there's some funding mechanisms out there that aren't as constrained. So PCORI, very much interested in doing some of this stuff. And they have some fun. I've seen some funding requests out there to do more holistic stuff. ARPA-H, the new NIH research, anything that's like DARPA, that gets they have a tolerance for a higher failure rate. I think that ARPA-H money could be used to do some of this more innovative stuff wrapped around what CMS wants to do. You know, getting some of the foundations in the state or some of the national foundations that are interested. Getting RWJ to step up to the plate. I put my good friend Rich Best on the plate here getting them to support, you know, some of the more expansive wraparound things you might want to do to augment that, and then make sure that you put it all together as a single report, so that you're saying, yeah, this work, we're able to prove this, we're going to improve the healthcare of these individuals, but here's what we were able to do when we wrapped around a more population-based approach. And again, here's the economic savings, here's the health improvement that we were able to get from that.
Commissioner Tosin Olafiju is co-chair of our you and also affiliated with Coppin State University School of Nursing as well as Morgan State University faculty.
Thank you. Excellent presentation. My question is around the conversation that we had earlier about budget cuts and the role that we can play in better telling our stories. Now, I've observed, based on, I currently serve as co-chair at MGPHA, and in my observation, and also as governmental public health worker for the years, I've noticed that, the spirit of advocacy is not really right among governmental public health workers. Now, I don't know why. So the question is, what role does governmental, local department and state health department, what role do they have, to play in terms of turning on that switch, empowering their workforce to be better advocates? Because you see the medical association, they are out there in numbers. They're out there, speaking to their issues, and you see that change happen. Same as nurses. But in the public health workforce, time and time again, you see more of the advocacy organizations and other groups doing most of the advocacy work. And some of it, comes from fear or not knowing where to, draw the line, because I talked to some of my colleagues, in local clients, like, well, can we not? So what role do local departments and state departments have to play, empowering their staff to be better advocates?
Well, I think the first thing you ought to do is, again, you may not be able to do that as government employees, but I can. They ought to join the Maryland Public Health Association to start with, okay? And be part of that process. And they need to be careful. They got to do it on their own time. They can't use their, their personal communications devices, et cetera, et cetera. But they can be part of that process, and they can make the Maryland Public Health Association in this state very strong. And then the association can partner with other advocacy groups on a common health agenda. And then they can go to legislature every legislative session and say, here's our legislative agenda. And this is what we want you to do. And I would encourage people to do that. You don't lose your Second Amendment rights because you got a government job. Now, sometimes it's not wise. There are many times that it would have been unwise for me to say what I thought as the either deputy or state health commissioner. Okay. So I get somebody else to say it for me. Okay. And I often, and this is not a secret, but I would often sit down right before the legislative session with the various advocates, including the pro-tobacco advocates. And we would have a soul-saving discussion about the session. What I could do and what I couldn't do and where I could. And, I would hear, quite frankly, where they thought I should go. Often they wanted me to go further than I could go. And then I'd go to the governor's office and I'd get some idea of how far. I knew what the governor's public stance was, and I got some sense of what the governor's private stance was. And then I figured out how I had to navigate myself within that window. And I was perfectly pleased to have somebody tell me to do something I wanted to do anyway. Okay. And sometimes they wanted me to do stuff more than I could do, but they knew up front how far I could go. And that didn't mean they wouldn't beat me up. And I had many legislators call me in and say, you're in for whipping today. Yeah, I understand that. And they go beat me up, and then, we go hang out later. And regardless of party, and I think that's important. And I think for us in public health, governmental public health, we need to spend a lot of time. I went to a lot of parades in small communities in Maryland. I spent a lot of backyard barbecues, regardless of party. I went out and hung out with those folks. My goal was to find out what they were thinking. And I'll tell you why that lesson, I learned that in DC. Just one quick war story. So I was, Queen of England came to DC. And then of course there was the obligatory reverse visit for some of the lower income kids in DC to go to England. Primarily wards, I think 7 and 8 were going to go. And I was in the office of the head of the Human Services Committee, down in H.R. Crawford. He'd bring me in once a month to make sure I understood who was really in charge of health in the city. So I would go in and get my whipping from HR. And some of these kids were there that were going on the trip. And I'm still trying to figure out how I could get myself invited to go on the trip too. But we were having a conversation about the kids' experience, and I was talking about how wonderful these kids would have been going to London. I was talking about all the things I would like to do. When I went to London, Buckingham Palace and Queen, doing this and doing that. And I suddenly realized I was not communicating with him. And he said, you need to understand, these kids are not excited about going to England. Really? He said, no, they're excited about going to the National Airport. They live in Ward 7 and 8. They see the planes coming over the hill. They live in a city 10 square miles. They've never been to the airport. Now, once they get on the plane and they get to London, they're going to have a wonderful time. But their world was limited to going to the airport because that's what they knew they were going to do. Okay? So I then spent a lot of time over in Ward 7 and 8, sitting down, trying to understand folks, listening to them, talking to the members of the city council, trying to understand those perspectives, which I hopefully then brought some of that to the table because, I grew up in Chicago on the South Side, but I didn't grow up in the hood. My life experience was not their life experience. Even though we had a clinic that we did once a week in Ward 8 in DC. My life experience was not their life experiences. So I think one of the things you got to do is you got to get out there and understand the life experiences. And once you make those relationships with members of the legislature, it's a whole lot easier for you to walk in and say, look, here are the implications for me cutting the budget to your constituents. Here's what I can't do. Here's what I can do. Here's what the compromises are.
Thank you. We have had a member of the public who's joined us today, Rosalie Wright, very patiently waiting for the question. I'm looking to see if she's still online. Rosalie, yeah, I think what we'll do, Dr. Benjamin, she's no longer online. We'll follow up with her independently and make sure to connect your question.
I'll be happy to.
Thank you so much. Really, what an incredible honor, again, to have your presence here, your thoughts, your genius, really. And we're just so very appreciative of you taking the time to be here today and speak with our commission. And I'm certain that this is going to stimulate some significant discussion across the commissioners and certainly at the work group level as well. So thank you.
Thank you very much.
Thank you.
All right.
I'm going to take the liberty of flipping a couple items on our agenda. We're actually going to move into the short recess, and then we'll, after the short recess, we'll proceed with our remaining two major items of the agenda. Dr. Benjamin, during the recess, we'd love to take pictures with you if you don't mind.
Oh, sure, absolutely.
Thank you. All right, wonderful. So thank you, everybody online. We're moving into a short recess, and we'll reconvene in about 10 minutes. So 3:52, I think, if that's correct. Yeah, 3:52, we'll reconvene, and then we'll wrap up the meeting after that. Thank you. 2 minutes. Do you mind getting the video or your phone? Have all the commissioners return to their seats, and we'll go ahead and restart. Thank you again for everybody who's continuing to stay online and continue with the meeting. Now we're going to have our commission manager Shane Hatchett give a brief update on progress of the commission's work since we've last met.
Okay. All right.
Sorry, just a quick check. If I could get a thumbs up from somebody online to confirm that you're able to hear us. Wonderful.
All right,
Thank
we're
you.
good. Excellent. Okay, in the interest of time, I'm really just going to breeze kind of through this. Again, sent out these materials yesterday, so a lot of this can be viewed on your own, but wanted to make sure we spent just a few moments talking about a couple important things in particular. So of course, we are really coming up closely to a couple major milestones. In particular, next month, we will be kicking off our deep dives, which will focus on one of the topical areas of our work groups. And since Fran isn't here for me to induce the anxiety, I will do that later. But governance and organizational capabilities will be our first work group to go through this deep dive, and I'll talk a little bit more about what that looks like in a few moments. But the other piece of this that I want to kind of highlight is we're starting to get close to wrapping up our site visits and listening sessions. So we've collected a significant amount of really rich qualitative information from those, and hope to get those wrapped up in the October timeframe here. We're still working on getting the Baltimore City site visit and listening sessions set up. Obviously, acknowledging that the recent turnover with the health department there has presented some additional logistical challenges. So we're working through that with them to figure out what is the most appropriate way to approach that. We've also mapped out a couple other speakers for the next few sessions. And since we want to really make sure we're focusing on the deep dives and having enough time for us to deeply get into the topics and for the commissioners to get an opportunity to interact with the work groups and the information, we will only be having one guest speaker at each of the upcoming meetings. And so if it looks like we're kind of pulling back on that, that's why. It's an intentional effort to make sure that we've got plenty of time for the dialogue with those deep dives. Again, if there are folks that you think are really important for us to continue reaching out to and having come speak here, we'd love to get that input. But so far, we've got Chad Furman from MBH coming next month, and he'll be talking about primary care. And then we're working on setting up a workforce panel in October to really kind of build on some of the conversation we've had today and some of the conversation from the last meeting in particular about different access challenges. In terms of activity, really we've been primarily focused on getting the charters finalized. Several of the work groups have focused specifically on that and provided some really great feedback. So I would ask that if you're working with your work groups and co-chairs, please make sure that we get that wrapped up here soon. I would say probably by the end of August makes the most sense, so that we kind of have that set in stone and can kind of operate from that, because it will feed into the deep dive templates that we'll be building out. The deep dives themselves, I shared the template at the leadership meeting last month, as well as with some of the work groups, and kind of walked through what each of those sections were. And so I think we've had some pretty good conversation recently. I truly expect that, once we have this first one go in September, we're going to find things that make sense for us to tweak and modify. So, don't expect that it's necessarily set in stone, but that we would be able to adapt that to make sense for what our needs are going forward. again, and I really can't overstate the importance of this, you know, the deep dive PowerPoint is not the end product here. It is really meant to be a facilitating tool for the conversations that the commissioners have expressed that they really want to get into. What are the work groups doing? What have they been studying? What are the findings that they're starting to see with respect to their respective domains? And so it's going to be just absolutely critical that commissioners come well prepared to ask questions, dive into the different discussion topics with the work group co-chairs. And that is really going to be kind of a point for us to also check and say, you know, has the work group done what we need them to do in terms of exploring this topic? Are there areas that seem to be missing or glaringly obvious to other people that, you know, maybe just weren't obvious to the group at the time that we need to give them some guidance on? And so it's really going to be an opportunity to kind of level set and make sure we've got a good plan going forward for the spring, which is when we'll come back and do recommendation presentations with each of the work groups. So it's not the end of the world, but at the same time, it is going to be critical to kind of setting us up for that path of being able to write our final interim report as well as the final report next year. And that takes me to another thing that I want to mention, which is with respect to this year, we have a final interim report that's due December 1st. So logistically, that means we need to have a draft here November 7th when we meet. And the way that will work is we'll have a draft put together. We'll talk about that during our regular session. Any sort of changes or modifications that are necessary, we'll take that down and make sure that gets done, but staff will submit that on behalf of the commission once it's done and approved as amended during that meeting so that we can comply with the statute. Our December meeting is December 5th, so it just doesn't quite work, and we want to make sure we keep the legislature happy. And to that point, you know, we've talked a lot today about health equity, and we've talked a lot about that in leadership meetings and some of our work groups. We really want to make sure that we have that sufficiently reflected in our final, or our interim report this coming December. So more to come on that, but I would strongly encourage folks to look at the template for the deep dive, because that's really going to help get us prepared for that. Oh, I should have looked ahead to my slides. Okay. Nothing else to add there. Listening sessions, as I mentioned, they're going well. I just want to make a plug for Talbot County coming up and the Eastern 4 listening session. They are so excited to have us at their facility. We will ideally be having that listening session hybrid. So they're working out the technology kinks as we speak, but believe that we'll be able to have that just to increase accessibility. Would also love to give a shout out to Montgomery County, who hosted us earlier this week. It was a really great session for the site visit as well as the listening session. We were able to, again, have that one hybrid as well. And I think, you know, because of that, we ended up getting a couple more speakers than we would have normally. So it's been a great activity to do, but it's definitely a real effort to make this happen. So somewhat looking forward to when this is in the rearview mirror, but at the same time, it is definitely important to collect information as we go along. So that is pretty much all I have. Any questions for me? Yes, Fran.
A question about the listening session. Have we got a protocol of how we will respond back after the listening session to the host county health department, to the electeds, may have been there, to the general public at large? So I kind of feel like the information in, but you know,
yeah,
back to the great. So how we keep that?
The short answer is we haven't decided. Yeah, but I agree with you. That's actually something that's come up a couple times from public speakers, that they really would like to know what's being done with the information. And actually, Howard County was really the first place that I think we heard that explicitly. And so that's kind of been on our mind since then. And once we, I think, get all the information together and think through that, we can start to figure out how do we turn that into something that others can point back to and say, you know, I understand now how you used my testimony.
And I think also as a matter of courtesy, it would be good to send this, on behalf of the commission, send back a thank you to the host as well as to the electeds that came. You know, that would be before we had sort of this whole thing digested, that you brought out the point, here's reflected in our report. That's good, that's important, but more good.
Yeah, I mean, that part we do. I think the critical piece though is connecting how the input, like you said, how the input is tying into the work of the commission and what the commission is putting forward. I think maybe we can talk about that at the kind of the commission support level, and then bring it to the commissioners for additional discussion. And if you have any specific ideas or suggestions, we'd love to gather that as well.
I just think it's, you know, it's a matter of credibility and the beat.
Yeah, agreed. Absolutely great point. Thank you.
Any other questions?
All right, excellent. Thank you so much. I appreciate that, Shane. And of course, appreciate your leadership of our support team, who is working really hard and across the work groups, across the commission, and many of them on a volunteer basis to support the work of the commissions. Thank you all for involved in supporting the commission. I'm going to turn it over to Dr. Dushanka Kleinman, again, our senior technical advisor to our commission, to introduce our academic partners who are assisting with the public health assessment.
Thank you very much. I'm delighted to do the introduction. I just want to say a few words in advance to sort of set the scene. The commission is an assessment tool, all the commissioners. The working groups are assessment components, that streams that feed in. So a lot of the work that has been ongoing is the foundation for the assessment that we're going to tell you about right now. This is an additional complement of both primary and secondary data collection and analysis. And in that way, I think we're really fortunate to have our representatives of the academic partners here. So our two universities that have partnered together, Morgan State University and University of Maryland, have come together and formed an approach and a strategy to address what the commissioners have asked for. And so I'd like to introduce our team. Amelia Aria, who is not here today, is from the University of Maryland team, and she partners with Dr. Anita Hawkins from Morgan State. The two of them are sort of leading the effort, and then with them, I have to acknowledge Dean Kim Sidnor also is part of the team from Morgan State as well. And with Dr. Hawkins is Brittany Busby, who is the senior faculty specialist from the School of Public Health, and also Dr. Melinda Kennedy. So we're very pleased to have you here. We're looking forward to the overview, and then I know that it will stimulate a lot of questions afterwards. So we'll go through the whole presentation with some additional commentary, and then turn it over to discussion. Well, thank you. And for those joining online, I know because the camera is more focused on the room, yet our speakers are at the podium. If you tune into video feed, she's actually having her camera on our speakers. So you can see her. Thank you.
Thank you very much, everyone. Thank you for the introductions, and thank you for the opportunity to share with you all today an overview of our assessment approach. I did want to share on behalf of Dr. Ria just her apologies for missing the meeting today, but I'm sure you will be hearing from her in the future throughout this whole fall into the spring as we conduct these assessment activities. Great. So as Dushanka shared, Morgan State University and University of Maryland School of Public Health are the academic partners to the commission, and we are working as a team collaborating to lead these assessment activities. Great. So to start, I just wanted to give you an overview of the breadth of assessment activities that we are engaging in the upcoming months. You will see that there are many different activities because the goal here specifically is to capture perspectives, voices, opinions from as broad of an audience as we can capture. So that's why we have tailored many different types of activities to hopefully capture those perspectives. So starting first with perspectives from the public, we have online public comments, listening sessions, and a public survey as well. So I believe the comments and the sessions are underway already. The public survey is in the early phases of being developed. So Dr. Hawkins will speak more to that in a few minutes. We also have what we're calling our on-the-ground perspectives. This is where we want to hear from both people working currently in local and state health departments, as well as working at the organizations around the state whose work leads them to interact with our health departments. Those individuals, some will also be invited to participate in focus groups centered around particular themes. And then there will also be site visit field notes from the visits that are currently happening to the local health departments around the state. Then we also have some other pieces of quantitative information that we will access. So one is the organizational survey that will be sent out again to the health departments around the state. And then we'll also be able to utilize some existing survey data as well, namely from NACCHO, their local health department profiles surveys and the forces of change surveys that they do. We will be able to use that existing data to our advantage as well. Okay, so this is just an overview of the number of components that make up the overall approach to assessment. Right, we wanted to give you just, again, an overview of the timeline. This is to help keep us on track and also for you to know when you can expect updates throughout this process. Starting with some of the activities that have already are underway this summer. I know many of you have been very hard at work making these components happen. So the first is developing assessment questions. And that's really where the early work of the work groups come in with developing the list of assessment questions that they sent to us a few months back. I'm going to speak much more to that, but that really has served as the basis for much of the work that has been done since. There are also the site visits, listening sessions, the online public comments all underway. And we are also working on finalizing participant lists to identify individuals who will be invited to participate in the interviews and focus groups that I just mentioned. Great. The goal is to have all of those participants identified ideally by the end of August so that when September comes, early to mid-September, we will be able to jump right into our ongoing primary data collection. So that involves the stakeholder interviews, key informant interviews. Speak in a few minutes about who our stakeholders and key informants are in this process. Focus groups, the organizational survey, the public survey. This fall is going to be a very busy time for collecting as much data as we can from all of those different voices. It's not noted as its own item on this timeline, but I did also want to acknowledge that throughout that phase, we will hopefully be providing ongoing updates to the commission. At these monthly meetings, we'll be able to come back and share how the process is going, and if we have any early findings, anything where we'd like your input. You will be hearing from us, I'm sure, throughout this fall. Right, into October, November, December, that is when we will be working on secondary data analysis. So again, that's primarily the NACCHO surveys that I mentioned a few minutes ago. I believe contact has already been made with NACCHO to get the ball rolling there in terms of accessing the data, and we anticipate being able to start analysis kind of mid-fall, probably. So as you can see there, those two activities stop around the end of the year. Ideally, as much as possible, we'd like to wrap up the interviews and focus groups before Thanksgiving because we know winter holidays, year-end activities at work, that gets really busy. But certainly by the end of 2024, we want to have all of the data collected so that in the new year, we can jump right into the analysis. That's going to be a very busy month for that. That will include, importantly, not just analysis of the data within each component as it's collected, but the triangulation of all of this information. We want to have enough time to look across all of the different sources, all of the different voices to understand where are findings aligning, importantly, where are findings converging, where do different groups have different feelings, perspectives. That will all be in January. In February, we hope to come back to you again to share preliminary findings and with our work groups, commissioners, everyone, because we think that your input will be very valuable at that point in terms of refining the findings. And also some of the work being done by the work groups that isn't necessarily captured in the activities I described today, if there's information from those activities that we'll be able to pull in as well to come up with our final findings of the assessment. And then throughout the spring, we'll work on preparing our final report. Just an overview of what's to come. All right, so as I mentioned, the key assessment activity that has already been done by the work groups was the ideas, the questions that were generated by the work groups in terms of what they want to know from the assessment activities. We received more than 200 questions from the work groups, and it was really apparent throughout that just the time and thought that went into developing all those questions. So we did want to say a very big thank you to the work groups for all of that work, because that has given us such a solid foundation from which to pull our assessment questions for the various components. And so then to give you just an overview of the kinds of themes that came from the work group questions, we went through, we categorized them, we coded them, and these were where we tended to see themes within those questions. First one is organizational structure. So that gets into governance, importantly delivering roles. So this is where we saw questions like, for someone working in a local health department, do you see the health department as primarily a state agency, a local agency? From the state's perspective, how do they view the role of the local health agencies? An example from governance is, are there certain governance processes for a local health department that either help or hinder their ability to work with outside partner organizations? Many questions about funding, primarily around decision-making with the allocation. So, you know, how transparent do you think the process is from the state and within your local health department when it comes to the allocation of funding? Do you use data to drive allocation decisions? Those types of questions. Funding sources as well. There were a couple of questions about external sources of funding. Are they able to secure external grants from specific organizations? For communicating health information, this is where there are questions about specific tools and methods that are used to communicate this information. So for example, social media was one. Communication about specific issues, COVID-19 came up a few times there. And that is also where, in particular, we see engagement with the public as the public perspective, I should say, as a key topic. So understanding both from the health department's perspective, how they communicate outwards, but then from the public perspective, do they feel that they received that information? Do they wish they received it a different way? What types of information do they want from their local health department? So the public perspective will be particularly important there. With technology and data systems, many questions about AI as a very emerging issue, a very timely issue. Understanding how the health departments are using AI, if at all. Tracking health metrics was an interesting one. So looking at to what extent health departments have been able to automate the tracking of health metrics versus what is still done essentially by hand. And are there data systems that they wish they had access to help with more automation of processes like that? And then some questions about specific types of systems. So financial systems is there, HR data systems was mentioned, electronic health records, importantly, there are many questions about that. CRISP as another example. So lots of questions about specific programs. Workforce, I would say actually was more of a cross-cutting theme. Many work groups had questions about workforce. Most of them, I would say, were regarding training and continuing education. So both for the people at your organization, what training do they have? What training has been most helpful for them in that role? And then what training needs do you have? What training do you wish you could provide to your employees? In terms of recruitment and retention, there are some specific questions such as, I know we mentioned primary care physicians, being able to attract them to certain areas of the state. There are questions about that. There are questions about salary growth and education requirements in job descriptions, how that helps or hinders the ability to hire. As we mentioned, the pipeline from the universities to the health department, that's always near and dear to my heart at the University of Maryland, so I was happy to hear that mentioned. And there were questions about that as well. All right, Medical Reserve Corps, of course, we are going to be assessing the role of that organization as well in all of this. And then partner and public engagement. So from the health department's perspectives, who do they see as their key partners in the work that they do? And what strategies do they have for working effectively with those partners? And then from our outside organizations' perspectives, how are they able to work with the health departments? Do they see the health department as a key partner in the work that they do? And again, the public perspective will be very important here because the community is a key partner in all of this. They clearly see the community as one of their key partners. So how are health departments and other organizations able to engage with the public? Do they wish they had different strategies to do that? Are they helpful with or happy with the extent to which they're able to engage right now? And then from the public's perspective, the same questions. So those were all of the themes. Oh, and I'm sorry, at the bottom there, it's a little hard to see in person. I apologize for that. Other cross-cutting topics that came up throughout all of this was first just challenges and needs. So understanding from the health departments, are there certain things they need to be able to work more efficiently, more effectively? And then same thing from the outside organizations' perspectives. If they have any challenges they've encountered, do they want to work more with health departments, but certain things are getting in the way? What are those issues? And then equity as well, certainly too. Equity was built into all of these themes. We had equity related questions, I think, from almost every work group. So for example, how is data used, like demographic characteristics? Do health departments use those to make decisions about how to allocate funding to certain areas of counties or to certain programs to ensure equitable services across the whole county or the whole jurisdiction that we serve? So equity will be built into all of this. So again, you can see many, many different types of questions. So much thought put into it. So we are very grateful to have such a solid foundation from which to build all of our assessment work upon. And that is our goal. We really want to use this as the basis for the assessments that we developed. I did want to acknowledge too, we looked at a couple other sources as well. It's a little small, I apologize. But this is from the Public Health Accreditation Board. This is their foundational capabilities for health departments. And you can see there are some that overlap quite a bit with the themes that came from the work groups. Equity as one, communication as one, community partnerships as one. And there are some that just came up less, I would say, in terms of themes from the work group. So policy development is mentioned here. I wouldn't say I saw many questions about policy development in the work group questions specifically. We did not show the graphic, but luckily Dr. Benjamin showed it to refresh our memory earlier of the CDC, the 10 essential services. So that also we reviewed as well to build into all of this. And so those three sources kind of will build a foundation for our assessment questions. All right, so now I'm going to jump into a few of these specific types of assessment activities, the first being interviews. And I want to differentiate first the difference between our stakeholder interviews and our key informant interviews. So our stakeholder interviews, the audience for these ones are going to be those working at local health departments, the officers and deputies as well. Some individuals from the Maryland Department of Health, so some of the offices, administrations that you see listed on the slide will be invited to participate. And then also from the local health improvement coalitions, if the LHIC chairs in a certain jurisdiction are different than the health department lead, the LHIC chairs, co-chairs might be invited to participate as well. So the goal of these interviews is from their experience, again, there are on the ground perspectives, we're calling it, what are their foundational public health capabilities as they exist right now? And then also what is their vision for the future? Right, for our key informant interviews, we have several key informants that were actually identified within the legislation that established the commission. So you can see there, those are from some of the key commissions and other health other agencies around the state that have been named. And we are still working on finalizing this list. But some of the other types of key informants that have been identified so far include public health and healthcare association partners, advocacy groups, local government officials. So other organizations will be pulled into this. And the goal there is understanding how their organization functions within the public health system in Maryland, how they see their role, their ability to work with the local health department, state health departments. That will be the topic there. So there are about 35 key informants interviewed to date. identified to date, and then 55 stakeholders who have been identified to date. So altogether, we think we'll be completing around 100 interviews. Right. Just going to very briefly describe some of the process for the interviews, and then I'll get into the content of the interviews in a minute. But to start, we're working right now, as I mentioned, on the identification of the stakeholders and key informants. That's top priority right now. For recruitment, we were thinking that it would be helpful to have an introductory email from the commission, potentially commission co-chairs or whoever else the commissioners decide is the appropriate source for that, but an introductory email to explain the assessments that are taking place and the goals of the commission assessment. We think this will be helpful because particularly for the health officers, they are going to be invited to participate in a couple of different components, the interview being a key one, but also focus groups, potentially the organizational survey. And I think for them to start having an overview of the different components and what the purpose of all of this is will be helpful to have up front. So after that is hopefully sent, Dr. Ria will invite them to participate. We'll do 3 emails, 1 phone call as a recruitment strategy. And then importantly, I wanted to mention at this time, we're thinking that if there are certain individuals for whom we have no response, where there are concerns of representativeness of the data we're collecting, that we may come back to the commission at that point to ask for strategies about reaching these individuals. So for example, if there's one particular region of the state, say Eastern Shore, we aren't getting many responses from individuals in the Eastern Shore. We don't want to leave them out. You know, we might come back and say, okay, do you have any suggestions? Can you help with that? For administering the interviews, so Amelia Ria, Melinda Kennedy will be our interviewers for this process. Just want to note, we are going to send an overview of the interview questions ahead of time because they are, I would say, pretty thought-provoking questions. We do want to give them a little bit of time to think through some of their responses beforehand, anticipate what kind of questions they'll be asked, and we think that will help the interviews run more efficiently. Great. And then importantly, we do really want the interviewees to feel very comfortable speaking freely. So we are going to have confidential interviews. They'll be told up front that this is confidential. We're not going to record them. And we think that that will help as well. Right. Some key considerations with the interviews. The number one, I would say here is the time limit. We are doing our best to be very respectful of their time. Again, particularly for individuals who are going to be invited to participate in multiple components throughout this full assessment process. We know they're very busy people and we just can't be eating up hours of their time. So we are doing our best to keep the interviews to about 40, maybe 45 minutes. But that means that we have to be very efficient with our time. We are also trying to balance the breadth of the questions versus the depth of the information that we captured, because as Amelia put it, we don't want to capture information that's a mile wide and an inch deep. We think that it'll be more helpful if we can prioritize certain topics to get more in-depth actionable responses. That will serve us better as we head into our findings, our final report. That is where the themes from the work group questions are particularly helpful because that has signaled to us where the priorities of the work groups lie, and we'll be able to, tailor the interview questions to focus on those areas. These are also going to be open-ended questions in this interview to differentiate it from the organizational survey that will happen later. The organizational survey will lend itself more towards that quantitative data, more yes/no questions, things like that. But we don't want to duplicate any of those efforts here. So this is really very open-ended to get truly just their thoughts, their perspectives. It is semi-structured to keep us on track because, again, we're trying to be efficient with time, but very open-ended. Right. In terms of the general structure of the stakeholder interviews, so again, by starting with the work group suggested questions as our base, considering essential public health services, our FAB foundational capabilities, these are the sections that we are hoping to get through with all of these interviews: governance, structure, workforce, partnerships. Again, very similar to the themes that I shared earlier from the work group questions. The general structure within each section will be, first, we'll define what the section is covering. When we say governance, we say structure, we know what we're referring to because we are enmeshed in these work group questions. But just to start everyone else on the same page, especially with the external organizations outside of health departments, we'll start by defining the kind of information we're hoping to capture. We'll ask them to describe the current status of the health department or the organization for that section. And then probe as necessary. One, make sure that we are capturing these successes. What is working really well for your health department right now? And then also ask about challenges, perceived barriers. So we'll ask very open-ended up front and then probe as necessary to get that information. And then we'll end on opportunities for the future. So when Dr. Benjamin mentioned transformational change earlier, I jotted that down because this is exactly what that section is going to be covering. I really liked that term for it. So we want to know, what is their vision for the transformational change that they want to see in Maryland? What do they think is possible in the state? This is the very visionary part of the interview. Right, so this is just examples of questions that have been developed so far. We have not finalized the questionnaires, but we just wanted to give you a sense of the open-ended nature of the items. So I'll give you all a minute just to read through it. Out. And then for the key informant interviews, it is a pretty similar structure to what I just mentioned. The sections are a little bit different just because it's trying to capture slightly different information. So for example, the governance question we did not include for this one. Because again, these are external to the health department. And then importantly for this one, because we have different types of key informants, as I mentioned earlier, we are going to have several versions of the interview to make sure that we are asking questions that are appropriate to the type of organization in which they work. So this is one example. Just we started with a state agency director. So we have Department of X here, very mysterious. So these are the types of open-ended questions that we might ask someone there. So you can see it is pretty tailored to someone working in the government, asking about the community members that they serve, how they communicate with them, what kinds of partnerships exist between public health partners and that department, just like that. And as another example, we have a legislator or a more policy-oriented individual. So again, we're asking them about how information is communicated. Communication certainly is very cross-cutting across all of this. There are many, many questions about communication throughout all of this, but you can see there. But then we also do have, some of the specific sections that we mentioned. We have a sub-question about workforce. We want to, know their understanding of the funding issues related to public health. So this is how we hope to capture the information from these types of individuals. All right. Going to briefly touch on some of the focus groups. So this is still very much not finalized in a way that we appreciate your input today if you have any. These are the proposed focus group topics. So again, these are going to be organized more thematically. So these are the focus groups that we think will be held so far. The participants in the focus groups will mostly come from health departments, we believe at this time, local and hopefully state as well, is the plan there. There are also certain networks that have been identified as possible connections here. So public information officers, for example, accreditation needs, they might come into the focus group as well. All right. Turn it over to Dr. Hawkins.
Thank you, Brittany. Brittany has given a really wonderful overview of the assessment and the details of the assessment that really involve many of the partners and stakeholders and organizations that are really more involved with and understanding public health. But it is important for us to understand the public's perspective. And so you've begun that already with the with the comments, the public comment period, the listening sessions. Shane spoke about where we are with updates on you on those listening sessions. Those themes that are being explored through the focus groups, the interviews, stakeholder interviews from the stakeholders and the key informants. Those same themes are emerging in those public listening sessions. So one of the differences that you might hear is that the public listening sessions, the purpose of those, for them to comment from the public's perspective on those areas, on funding, on workforce. So it's been open. Those are open. They're not surveys. They come and give public comment. And the ones that have been thus far actually are reflecting information on those various things that have been thus far. So the rest of the listening sessions, we will begin to, when they're completed, pull them all together collectively, not just because collectively to look at them across the board. Now, there are comments online as well, and they sort of are people who are not at the listening sessions, but they're open, and if I understand, they're open through the end of August, but they've expanded it through October. The Communication and Public Engagement Committee had a lot of questions that focused on a public perspective. They had questions that also are throughout the other assessment tools, but specifically questions that required feedback from the general public and not those involved. So we are working with the Communications and Public Engagement Committee to look at their questions, to help them refine those kinds of questions and examine another way, a public survey way of being able to capture that information across the state. So, and we're going to be discussing that over the next tomorrow and next week, and be able to finalize those activities.
All right. Now we have a few specific discussion points that we wanted to present to everyone to get input on, and then also some time for questions as well. But here we are, the discussion point of the presentation. So these are some of the topics that we would appreciate any input that you might have. The first one is encouraging participation from stakeholders and key informants. Again, we know we're asking for their time. That is very hard when they're very busy individuals. And so any strategies recommended by the crowd to encourage that participation. That's where we're doing our best. We come up with a few strategies. For example, the introductory email from the co-chairs we think will help. We are going to be offering phone and Zoom interviews, scheduled at quite a variety of times. Hopefully evening interviews will be available. We have some strategies like that, but any other recommendations from the audience are appreciated. One thing that has been mentioned, I'll go through all of these, I think, is that okay? And then we'll jump into the next one is the availability of MDH and other state partners to ensure comprehensive responses. You might have heard me just mention local health departments 1,000 times throughout this presentation. We want to be sure that we are creating enough opportunities as well to be assessing the state health department in all of this as well, in addition to the local health department, so that the findings that we have at the end of this are representative of the whole health department structure within the state. So I outlined here some of the planned participation in assessment right now. They will be invited to participate in stakeholder interviews, the organizational survey. We will get some data from the Public Health Workforce Interests and Needs surveys that the DeVomont Foundation is managing, PHWINS. Focus groups can be a bullet point here as well. We are hoping to have engagement from the state in the focus groups as well. Next is a discussion with the Communication and Public Engagement Work Group about data collection from the public. Mostly that's going to circle on the public survey that's mentioned a couple times, and I believe we're in the early phases of scheduling, hopefully, with them to work on that. And then further input on focus group content. So I showed those topics that have been suggested to date, but if there are any suggestions from the audience about other topics to consider, are there certain topics that could be combined somehow? Any guidance like that is helpful. Yeah. Start to
I have a suggestion on just ensuring participation, at least at local comments. There was perhaps a general email, last email from local departments, that one for Easter, telling people they would please participate. I think that would be really great. I really want to look forward to it. Strength for the organization. So
yes, absolutely.
In looking at the sample, thank you for the presentation. Very thoughtful. Looking at and reviewing simple questions that you shared, I don't see any kind of equity embedded in any of them specifically, though at the top of the presentation, there was a discussion surfaced from all of the committee, various committees that equity has to be woven in. And I wonder, I know these were just a sample, but I didn't see one. So wondering your thoughts on how we better do the thing wants to, just to waive consideration, need the consideration of equity in discussion. For example, when I think about workforce a lot, I think we need public health workers, but we also need diverse public health workers, right? We need to build a network of diverse by race, SOGI, age, all the things. Behavioral health in particular, like Black men. There are just so many ways you have to really get specific. And so when we think about workforce at a more granular level, we think about the diverse workforce. And in some sense, in some ways, you think, well, we just need anybody who's willing to come forward, but we know that that can't be enough. So just one thing, I wonder what folks' thoughts would be about, like, how hard is it to get people of color in behavioral health, and like, what are your thoughts on that, and how do we attract that subpopulation? Same with our class standards, how do we ensure language access? All those questions. So and that's just workforce. So just wondering thoughts on that. I would surface that as something to think about, and wonder if you guys had a number, you all have an opportunity.
Yes, absolutely. I appreciate that comment. That is part of our plan, absolutely, is that as we ask the questions, again, it's going to be very open-ended. And so within sections where equity is not addressed up front, that would be one of the probes that we have to follow up. So similar to how I said successes, challenges, we do want to make sure that we're capturing that information within each section. That is the plan. So we're working on how exactly the language will work to do that right now. Do we just ask up front? How do you address equity in XYZ versus other ways of phrasing those questions to see what kind of information we can capture? And I think particularly with the focus groups, behavioral health is a great example of a focus group that we are planning. And I think we'll be able to get some really good information in that setting as well. So yes, I appreciate that. That is part of the plan.
One way to address Neil's suggestion, I think, would be to include as one of the focus groups the individuals who oversee some of the recruitment and retention efforts within local health departments and then also the state health department. And to, within that context, I think it's really important to include topics of how we're ensuring a diverse public health workforce that's reflecting community that the agency serves, but then also what are the ongoing efforts of the agency to, related to diversity and equity and inclusion, not just community facing, but internal with their own workforce. And how is that effort internally with the workforce then translating to how we serve our community and the way we serve our community, the way we better engage. So maybe that would be at least one way to incorporate some of the thoughts that just mentioned.
Particularly what you find, as an aside, what you find in government is that we have a lot of Black workers who are not in leadership roles. They may be administrative workers, so they're your support staff, your secretaries, your janitorial, right? You may have a handful who are in leadership roles or people of color. And so is that a reflection of whatever community you're sitting in, right? It should better reflect, right? So we don't have this population that's sort of just the worker class, and then we have the leader class. And so those are complex, nuanced, delicate, button pushing observations, but have to be surfaced if we really want to break through. Just have to come up with it.
Yeah. Oh, I appreciate that. I think that button pushing nature of it, I think is why we're trying to be careful with how we will end up phrasing these questions. And I think potentially once we develop questions, we might be able to come back to the commission to get feedback on it because we want to be able to ask, capture that information effectively. So yes.
And something like that in terms of the diversity makeup of the workforce itself could be part of the organizational survey as a prelude to more open-ended questions and the key informative interviews. Right. Matt Levy, comment questions. Yeah. Matt is the co-chair of our data and information technology group.
Thank you for the presentation. Just a couple of quick thoughts. Yes, the focus groups, I think we might want to consider the environmental health directors as well, because a good part of what we do is environmental health, and it sometimes gets blurry on the edges of what we're doing and what we're not doing. The other thing, just more of a, for your stakeholder interviews, if you have the same, if you have all the questions, but they vary in topics, you might want to have, when you're talking about workforce, you might want to have the HR directors with the LH, with the leads in those stakeholder interviews, or the IT person in a health department with the local health officer, because they're going to answer, they may not know, and they're going to answer the question very differently than your IT person would, and they complement each other in the needs, I think. Same with HR. So just keep that in mind when you do your stakeholder interviews, to include at least proportions that are relevant to that. Might be helpful to include that.
Yeah, we think hopefully by having the questions sent up front, that might help a bit, that they'll be able to see, you know, oh, IT, do I need to go speak with someone about that before the interview? Another strategy that we had discussed was potentially for the organizational survey, having different sections of the survey, being able to assign those to different individuals within an organization, so that the IT focused questions would go to someone in IT, and that would be a time to hopefully capture their input as well. It's mostly a quantitative survey, but if there are individuals receiving that survey that we think might have other thoughts to share, we can add in some more open-ended questions there as well, in case they are not participating in stakeholder interviews.
And we do continue to have the public, the written comment option available online, and if the commission agrees, we can look at extending that through the entire assessment period of time. And if that's open to our public health workers who are working at local and state levels as well to use, if they are members of the Maryland public, just as anybody else.
Thank you. I want to piggyback on Dr. Beatty's point, because I think, and I hear you about having that survey and moving to different groups, but I think finance is a component of individuals who would be in the room that answer that very differently. So in addition to the HR person there, I think there's a role for finance. And I keep thinking local health departments, not mistaken, are like 80% or have 80% generally funded by grants, and 20% through for public health funds, right, or general funds. And so there's a different perspective on how you would respond based on where your funding allocation comes from. And then similarly, I think it would be great to have an understanding of how much leeway do local health departments have in being able to innovate. I think one of the things that we heard earlier from Dr. Benjamin was, what are the incentives that we can put forward for workforce development, and how do you get individuals who are trained in different capacities to actually see opportunities in local and state public health and government health departments? And I don't know what the opportunities are for us to be innovative in those thoughts and in those positions. So I don't know how you phrase that, but I think it would be important to get that perspective as well, because folks are just like, I'm working towards like this deliverable, and not necessarily have the opportunity to think outside of, to be creative and innovative in what possible.
Yeah, that was one thing that we discussed, particularly when I said the transformational change opportunities, visions for the future question. I think those types of questions will be built into that section. I think, you know, understanding innovation as they see it, as they're able to do, will come out of that section, I hope, because I do think that's important to capture.
And Fran, please.
Yeah, thank you. This is a pretty big undertaking in a short period of time, so I appreciate that. I've worked on food assessment in my life. So everybody has really good comments. Neil's opened the discussion about equity is really important. The governance committee really, we gave you some specific questions about equity and perceived barriers to equity, particularly with respect to leadership positions. So anyway, yeah, I think that I'm in my mind, I'm using, you have stakeholder interviews and informant interviews in my mind, and I'm seeing how it's working out. It looks like there's the internal people and the external, right? I mean, so, okay, because everybody's sort of a stakeholder, you know, right?
Yeah.
So on the internal interviews, 55 individuals, and we got 4 state people. That's a problem. That's a problem, okay? Because otherwise we will have an assessment of local health departments. We will have an assessment, we will have perceptions, we'll have observations, we'll have complaints, you know, might have some praise, but it'll all be coming, the voice will be local.
Yes.
And that's not our job. Our job is bigger than that. Our job is state. And so these 4 are really important, the MDH representatives that are named here, but the MDH HR person, the MDH IT person, the MDH budget person, the MDH PIO person, these are all hugely important to the policies. I won't say trickle down policies, but I mean, these are really important players. So MDH's participation, engagement on this is really going to be important. Otherwise, it's going to be a really lopsided assessment. No fault of anyone, unless we get that. Okay, so I think that's really important and the internal side. On the external side, again, it's like 35 people. Of those 35, 7 are, well, I can't quite figure out how the state local cut is. There are some very important external organizations that we should tap into. Starting with the state legislature. Okay, we have a delegate on this commission. We don't have the Senate seat is vacant. But if we go out and interview, you guys go out and interview all these people, these leaders, these workers in the community, and we don't ask some state legislators, they might get their nose out of shape. You know, they might say, well, what about me? I'm the chair of Senate Finance, or I'm the chair of House Governmental Operations. So I think we need to work through Delegate Heather. We need to get some legislators, at least invite them to participate. Because if we don't, and then we deliver a report about what the world is thinking, and we haven't invited legislators to comment, I think that would be a problem. There are other entities. The local environmental health people are important. So is Maryland Department of the Environment. So there's another state entity that has a lot of policy domain over environmental health. The state attorney general sets all the rules, and I can tell you from the governance committee, a lot of health officers are really confused about the state-local relationship with regard to who's my lawyer. And so we've had an opportunity to talk to the state people, the state assistant attorney general in our work group, and I think that would be a really good, as an example. I can give you some other examples of state entities that I think should not be overlooked. Because I think there's some, again, my point there is that we need more balance to this right now. It really feels like this is a local health department assessment. And we need to do that. Or try better.
We would love to try to do better. We will do better. Yes, absolutely. Some of those groups that you mentioned are on our big list right now. The key informant list in particular is not close to being finalized. So some of those we have identified the larger groups, but we haven't just named one specific. Who exactly is that going to be? Environmental health workers, for example, are on the long list right now. Legislation, absolutely, yes. We will be speaking, hoping to speak with some of the delegates.
Should work with our co-chairs on how best to engage participation with you all. So you don't want to make a cold call. You want to have some advance, and some of that can come from the co-chairs themselves, and then some individual commissioners have some input with some of the folks that you're going to want to talk to. So who's up?
Yeah, we appreciate that because, as I mentioned, the email to participate will be coming from Dr. Ria, and we do think just sending that email out into the world is not, that alone is not going to get us the response that we need to have a balanced perspective. So yes, however much we can, we would love to utilize any commissioners that have connections to these individuals.
Oh, one other thought that I just want, I don't want to flavor this, but there are other commissions that are working on very parallel issues. The Commission on Health Equity, the Commission on Behavioral Health, I think there's a women's commission. So these are state commissions. You know, and I don't know what their structures are, but some of them are super important to our work. So that's just another, I guess that would be a external key informant.
Yeah, or focus groups potentially as well. Yeah.
Great, excellent, great conversation. Really, really appreciate the work of University of Maryland School of Public Health and Oregon State University on this. I think, and also, of course, our ongoing partnership with CDC Foundation supporting a lot of this work as well. So thank you to all of you who are putting your just again, a big thank you to all the work group members and our support team who've helped this process get to where it is right now. I know we've got a few months ahead of us and a lot of questions happening, but it's going to be excellent content that's really going to drive forward the work. Thank you so much on that work. We're going to wrap up our meeting now with the last items. I'll move into announcements. And the next meeting of the commission, we're not quite yet adjourned, if you don't mind. The next meeting of the commission is September 5th from 2 p.m. to 5 p.m. here at the Prince George's County Government Building. And again, thank you to the Prince George's County Department of Health. I know Dr. Matthew is here, our Prince George's County Health Officer, so we really appreciate your hosting these meetings. I also want to put a call out again. Shane mentioned it earlier, but the upcoming listening session and site visit is at the Talbot County Health Department. We really need more commissioner representation at these site visits that the LHDs are putting a tremendous amount of effort and resources towards organizing. So I call upon you commissioners to please try to make it out to the Talbot County site visit next week and the listening session, the public listening session, as well as our work group co-chairs and work group members. Please get it on your calendar. Eastern Shore really isn't that far, and I promise you they will make it worth your travel and your time. They're exceptionally hardworking, and really, I know we're going to hear some great highlights of local public health in action from the Talbot County Health Department team. So before you leave, let Shane know, and we will get your RSVP reflected. And if you're joining us online, please send an email to, if you haven't already done the RSVP form, if you can try to make it on the afternoon of August 7th. I believe it starts around 1 or 1:30, 1 o'clock at the Talbot County Health Department. Please email the commission email at md.coph@maryland.gov. So we really need your participation, and the Talbot County Health Department needs to know ASAP because they're making arrangements for facilities and refreshments. Thank you. Nothing else in terms of deadlines and announcements. I will now officially adjourn if there's a motion that's supported to do so.
I move to adjourn.
Second. Okay, great. All in favor around the room adjourning our meeting? Well, thank you. Our commissioners joining us online.
I object to stay here.
And the citizen was done it now. I was doing that. So if everybody, all the commissioners online agree, we will be officially adjourning our meeting today. Thank you. And we can stop the video recording, please, and the audio. That would be great.